met together in 2007 after the Goals Conference where we were all chairs. There was a kind of a euphoric feeling that we made great progress in CML. We really had impacted the survival of patients, but we all had the realization that that great progress was very much limited to the high-income countries. And the idea of putting together a foundation of the people we knew and valued as our colleagues in CML research and clinicians to work towards getting that same benefit and beyond for the many CML patients around the world.
The knowledge in those days was moving very rapidly because we were learning along the way. We're still learning, but in those days, many things were unknown. And having the opportunity, many of us go to these big conferences and have the opportunity to go and present and hear our colleagues, but not everybody has that opportunity, and we wanted to bring that knowledge and expertise to everybody all over the world so that they could manage the patients better and understand these new concepts, and that was, I think, very, very important. One of the big challenges that we recognize is that not all the tools were available for everybody all over the world. Even then, the concept of monitoring, for example, was new, and even the standardization within the States and Europe and Australia, and it was a challenge, and yet for other places, even the diagnosis of CML was a big problem. So we wanted to address these and close those big gaps that we see between the patients that live in countries where there are resources and the countries where they don't have those resources.
Yeah. I mean, one of the big challenges we had was that the need was enormous, and we knew we could never completely meet that need. There will always be countries where you're not going to be able to get drug, you're not going to get PCR tests. We had to see what we could do most effectively. So we had to look at countries where there was enough good infrastructure, so the education and training on monitoring would actually have an impact, a measurable impact over that period. When we first came together, we wanted the focus to be predominantly improving outcomes for patients in low and middle income countries, so education, training, and we very much started our programs with that in mind. But it was always a long-term goal to move towards harnessing all of the incredible skills in our scientists and clinicians, bringing together those skills to create alliances, genomic alliances, TFR alliances, to actually improve outcomes for everybody.
And because the goals of therapy have evolved, also, we need to move with that change in our goals. From how do you diagnose, how do you manage these drugs. Now we're getting into TFR and the discovery of these genetic molecular abnormalities. So it's part of that is to bring that knowledge to everybody and make sure that when things like TFR are done, they're done well and safely for patients, and also collect that data so that we know what's happening in the real world. Now that more and more patients have been treated, I think that's made that evolution. We still have some of those initial goals, but new goals are emerging, and we're trying to address them as well. There's no question that there's still a lot of limitations on patients in many parts of the world, that they don't have access to the testing, the drugs, and also that the physicians who do a good work and try to do the best for their patients, they don't have access to all the information. Access to journals, to conferences, to all these things is limited. So unfortunately, those things still happen today, and they affect a very large percentage of the population worldwide. The other thing that's very challenging and disturbing is that in many of these countries, they're younger patients, so there's obviously much more at stake when these patients don't have access to treatment. And we still have a long way to go. Evolution of this knowledge that we were talking about, and make sure that the physicians have that access, so that even with the limited resources, that they can manage them the best possible way, because we cannot provide those resources. What we can do is help them with what they have, manage their patients the best way possible.
I mean, one of the programs we're most proud about over the past decade has been the preceptorship program that's brought clinicians from low and middle income countries to specialist centres, created really strong relationships that have that have continued over time, and it was frustrating to us, so we had to stop that during COVID. And we have a goal of reinitiating that as soon as we possibly can, and it's certainly one of our immediate goals at this point. I've always had huge respect for Jorge's intellect and compassion and his leadership in the field. And I think it's been great fun over the years. We've had various debates, not necessarily always taking the case that we were most believing in, but just the fun of having the debate to open up the issues for people. And that was, I think, that's one of my good memories of over the years, having great fun with Jorge with those debates.
For me, certainly the vision that the team had with starting with this foundation and the importance of bringing all these knowledge and all these care to everybody all over the world. That's been, I've gained a lot from that, just because it really is something that we probably sometimes don't think too much about. We are all in our own academic world and our own countries, and we sometimes don't think about that. So that has been a lot of fun. And I think that that learning from the daily interaction, and granted, sometimes we think different about a certain approach to a patient or something like that. But I think the great thing is that this is one of those relationships where you do think about learning and mediating and finding a common ground, rather than see who wins. It's nobody wins. It's we work together.
Yeah.
Yeah, I mean, if we had our way, we would love to continue helping people all over the world bring the best care possible to patients with CML. Ultimately, we would love to get everybody with CML cured, but I think a more realistic way is to with what you have, take the best care of the patients. And that's why, for example, the preceptorships were so good, because for doctors that already were established, and they came, they learned how a CML clinic was set up and then they brought that knowledge and adapted it to their countries, to their reality. So they didn't want to just copy it because they can't, but they learned enough to adapt, to bring progress, to make sure that whatever the outcomes were and whatever the resources, they could do better with what they had. And that's what we realistically want to aim for, that every patient has a better chance of survival from wherever they are, depending on where they live.
It's a massive challenge to get patients onto drugs and then monitor that drug for the rest of their lives. And I think that's when one of the drives to push more towards treatment-free remission, because that's a more manageable model for not just for in high-income countries, but in low-income countries where it's so difficult to do this long-term follow-up with patients. If we could find a program that could give maybe 2 years of therapy, and then the vast majority of patients would stop with a great confidence that was it, along the lines of what's been achieved in hepatitis C, where it's gone from a 1 year quite toxic therapy to a very short, sharp treatment. I'd love to think that's where we can head in the future.